Thank you very much, Dr. Sudhi Kothari, for inviting me to give this talk to the neurology subsection of the Indian Academy of Neurology. It's a pleasure to me to talk about sitting-up BPPV, which is a variant of posterior canal BPPV that our group at Favalor Foundation at Buenos Aires, Argentina, have recently described. Vestibular symptoms on sitting up is a common in the general population and in patients seen by vestibular medicine specialists. When you see a patient with these symptoms, you should, of course, rule out hemodynamic, orthostatic dizziness and vertigo, central positional nystagmus, vestibular migraine, PPPD, and structural abnormalities such as Chiari. Bucchi and Strothman reported in 2011 a variant of subjective vertigo without any oculomotor findings that they call BPPV type 2, in which patients complained of short spells of vertigo when sitting up from lateralized disc pie maneuver. They took a series of 200 outpatients with vertigo or dizziness. 20% of them corresponded to classic variants of BPPV, but a larger group of 43% corresponding to what they call type 2 BPPV. It was a subclass of subjective vertigo. The symptoms arise when sitting up from one side, this whole pie maneuver, but not from the other side. So the symptoms were lateralized, and in some patients, they documented posturographic truncal oscillations on sitting up that could be documented by means of a posturographic examination bed. And they proposed a posterior canal short arm canal lithiasis as putative mechanism for this syndrome. In 2018, we started to notice this striking nystagmus pattern. This was a lady in which we performed an Epley maneuver for a classical right posterior canal BPPV the week before, and in this retest we can see how on sitting up from this whole pike maneuver, a beating right torsional nystagmus starts to develop, and the nystagmus pattern is suggestive of an ampulofugal stimulatory deflection of the right posterior cupula. We can see how it has a velocity pattern, crescendo and decrescendo velocity pattern, but not as paroxysmal as the classical variant of posterior canal BPPV. Most of these patients have been recently treated by means of canal repositional maneuver for typical posterior canal BPPV ipsilateral to the suspected stimulated cupula on sitting up. This was another lady that was treated by a left posterior canal BPPV variant the week before. And we can see this beating left torsional nystagmus. In 2019, we published a series or retrospective series of 15 patients with this unusual nystagmus pattern on sitting up from this whole pike maneuver, and 8 of these patients were retested post-canal repositioning maneuver for typical posterior canal variant of PPPV treated by ourselves in our clinic, and 4 of them were early retested, so less than an hour had passed from the original canalite repositional maneuver. 4 of these patients' canalite repositioning maneuver were performed in other clinics for positional vertigo, but we didn't have any data regarding the findings on those maneuvers, and all of them had history of recurrent vertigo or PPPV, and most patients reported vertigo on sitting up and persistent non-positional disequilibrium. We retrospectively review the videoculography data of these patients in order to try to find out which could be the mechanism involved in this striking nystagmus. And here we can see the different findings on the different positional maneuvers. And as you see, there wasn't a standard protocol because of the retrospective nature of this first series. All patients presented with the inclusion criterion, that was the presence of upbeating nystagmus with torsional component on sitting up. We also found that other positional maneuvers could elicit either an upbeating ipsilateral torsional upbeating torsional nystagmus with the torsional component directed to the ipsilateral side of the suspected posterior cupula stimulated, or a less intense downbeating contratorsional component. We can see in our series how 8 out of 10 patient tested elicit an upbeating ipsilateral torsional component in head yaw test to the ipsilateral side to the torsional component, and how 8 out of 9 patients tested elicit a less intense down beating contralateral torsional component on nose down position that is equivalent to the third step of the Epley maneuver. We can see in this lady that was treated the week before for a right posterior canal PPPV, how rolling her head to the right elicit an upbeating and sustained right torsional nystagmus, and when we roll her head to the left, a less intense downbeating with left torsional component nystagmus starts to develop. This other lady who was treated for a left posterior canal BPPV the week before, we can see how on nose down position, a downbeating with a slight right torsional component, nystagmus start to develop. That is such a sustained downbeating nystagmus suggestive of an ampulopetal inhibitory deflection of the cupula. So we elaborated a model in order to try to explain the findings on the different positional maneuvers. We initially proposed a preampular canal lithiasis in which there is an anatomical restriction on the distal movement of the debris. On whole pike, the otoconia will not move distally, and on sitting up, otolith should move near the ampulla by means of the negative inertia force, and then it should move distally by gravity and provoke a displacement of the endolymph, which in turn would elicit an ampulofugal cupular deflection, and hence the upbeating torsional nystagmus. When the otoconia impacts on the anatomical restriction, it generates a kind of valve mechanism like a partial canalid sham that prevents the backflow of the endolymph, and so makes the cupula stay deflected for a longer period of time, and we see that non-paroxysmal crescendo and decrescendo nystagmus that lasts more than the typical variant of posterior canal BPPV. And this is an animation that will represent the model of the periampular canal lithiasis. Here we can see the two positions that mostly evoke nystagmus, which are those in which the periampular region of the posterior canal was closest to the vertical. In the follow-up of this series of patients, we saw no immediate response to cannulate repositioning maneuvers. We tried with Epley, Semont, and the Misemont maneuver without immediate success. All patients resolved their positional vertigo and nystagmus by means of domiciliary Brandarov exercises, and three of them switched to typical posterior canal BPPV, one switched to horizontal canal BPPV. All of them had normal MRIs, and three patients recurred with ipsilateral posterior canal BPPV months after the index episode, and recurred with sitting up vertigo after the realization of Epley maneuver. So we continue looking for these unusual patients in order to test our hypothesis. And when they arrived, we saw some things which caught our attention and generated more questions and hypotheses. For example, we saw that on some patients there was almost no latency since the sitting up to the beginning of the nystagmus beating, like on this patient. We also saw on some patients that the nystagmus arised when sitting up from the other side, and that was not congruent with our model, like this patient, eliciting a right torsional abbeating nystagmus when sitting up from left this whole pack maneuver. And also in some patients, we also noticed a persistent nystagmus when rolling the head to the symptomatic side, and also that the nystagmus increased its velocity when the neck was flexed by 30 degrees, assuming the whole pack maneuver, like in this patient. And the whole pack maneuver is the position in which the posterior canal cupula is exposed maximally to the action of gravity force. So we start to look for modulation in the pitch plane, and we can see how this patient elicits an upbeating torsional nystagmus on sitting up from practice whole pack maneuver. When we roll her head to the right in the whole pack position, we can see how an up beating right torsional nystagmus starts beating, that the nystagmus increased its velocity on flexing her neck. When we extend her neck by 20 degrees below horizontal plane, we can see how the nystagmus inhibits. And when we flex her neck again on the horizontal plane, we see the nystagmus starts beating with lesser velocity, and when we flex her neck again by 20 or 30 degrees, we can see that the nystagmus increase its velocity. We see how unrolling her head to the opposite side and downbeating contratorsional nystagmus starts beating, and it's maximal when the patient assumes the nose down position with the downbeating nystagmus with a slight left torsional component that suggests an inhibitory deflection of the right posterior cupula. In order to test our hypothesis, we also tested sitting up the patient with less acceleration, and we saw that despite of being of less intensity, the nystagmus still showed up. Some patients had persistent stimulatory and inhibitory nystagmus depending on the head position. We also saw modulation on the pitch axis of the nystagmus direction and intensity. So we start to think that there probably was a graviceptive heavy cupula involved in the sitting up phenomenon, but there is not much literature regarding that topic. When we think on a heavy posterior canal cupula, we usually think on an persistent abetting ipsilateral torsional nystagmus when the head is assuming the Dix-Hallpike position. But there are series that show that that position could set the posterior canal cupula in a neutral position and eliciting no nystagmus. And some other authors have proposed that that position could set the cupula in a ampulopetal deflected position, evoking an inhibitory downbeating contratorsional nystagmus. So we see how interindividual differences on cupula angulation and the extent of neck extension during the maneuver could set the cupula on an ampulofugally or ampulopetally deflected position or even a neutral position. So on the heavy cupula hypothesis, the Hall-Hallpike maneuver will be the position which will expose the posterior canal cupula maximally to the action of gravity, and so is the position with the greatest chances of eliciting a stimulatory upbeating torsional nystagmus. On the other hand, nose-down position is the other position that will expose the posterior cupula maximally to the action of gravity, but on the other direction, so eliciting an inhibitory down contratorsional nystagmus. And if there effectively is a posterior canal cupula involved in this phenomenon, a sitting position shouldn't be a neutral position because in that position there is some partial impact of the gravity force over the posterior cupula. So, an a kind of set point adaptation probably is taking place, a similar phenomenon to which that was described by David C. and the John Hopkins group with the magnetic vestibular stimulation and also experiences with constant acceleration chair rotation. So on 2022, we reported a second series of 18 patients presenting with sitting up BPPV. And here we use a set of pre-established positional maneuvers in order to better characterize the mechanism of posterior canal cupula modulation. And when the nystagmus was observed, head position was maintained for at least 1 minute or until nystagmus vanished. All subjects were examined by videoculography on a weekly basis for 3 weeks, and only then, if the condition continued, it was carried out every 2 or 3 weeks until they resolved their symptoms and positional nystagmus. So, age range from 47 to 78 years old, with a median of 62 years old, and there were 13 females. 12 patients presented with a documented or suggestive history of recurrent BPPV. 4 patients had personal history of migraine. 4 patients had been treated with deeply maneuver at our clinic for posterior canalolithiasis, and on 3 of them, the inclusion evaluation was an early retest in which less than an hour had passed from the original canalit repositioning maneuver. 3 patients were treated with the canalit reposition maneuver in other clinics, but we didn't have any data regarding the findings in those maneuvers. And time elapsed from the beginning of vestibular symptoms ranged from 2 days to 60 days with a median of 14 days. Most patients describe vertiginous symptoms when sitting up from bed, and most describe severe, persistent non-positional disequilibrium. And canalit reposition maneuvers were attempted on all patients without success for the treatment of the sitting up nystagmus in the initial evaluation, and all patients were prescribed with domiciliary Brandarov exercises. All of them resolved their symptoms between 2 and 45 days with a median of 14 days, and no patient showed evidence of central vestibular compromise in the neurological, oculomotor, nor on MRI examination. These were the findings on the different positional maneuvers or inclusion criterion. All but 1 patient presented the beating ipsilateral torsional nystagmus on sitting up from this whole pie maneuver, but this patient presented the nystagmus when sitting up from straight head hanging maneuver. So 16 out of 18 patients in our series showed an upbeating ipsilateral torsional component upbeating nystagmus, suggestive of a stimulatory persistent deflection of the posterior cupula, and 11 patients also show a downbeating contratorsional nystagmus suggestive of ampulofugal inhibitory deflection of the posterior cupula. So the persistent and direction changing nature of the nystagmus on these patients suggested the presence of a posterior graviceptive heavy cupula. 5 patients presented the upbeating torsional nystagmus on whole pike maneuver, but they did not present the downbeating nystagmus on nose down position. We think that those patients probably had a short arm posterior canalolithiasis because they present the persistent upbeating torsional nystagmus on whole pike position, in which the debris on the utricular side of the ampulla will persistently stimulate the ampulla, and in nose down position, the debris will fall towards the ampulla opening or towards the vestibule, relieving in that way the stimulation and evoking no nystagmus at all. We also saw that some patients presented with horizontal positional nystagmus, and we think that those findings could be due to free otoconia entering to the horizontal canal opening. So this is a nice case that I would like to show you. This was a man with 52 years old with previous history of typical BPPV, and he presented with positional vertigo for the last 24 hours. When we perform leaning test, he elicits a left horizontal nystagmus, and in bowing we can see a slight right beating nystagmus. On head yaw test, on the right position, we see a strong left horizontal nystagmus, and on left head yaw test, we can see a lighter right horizontal beating nystagmus. With a presumptive diagnosis of anterior arm left horizontal BPPV, the apogeotropic variant, we perform the Guffoni maneuver, and we follow with the Sumemaya maneuver. We can see here the geotropization of the horizontal nystagmus. So we move the otoliths to the posterior arm of the left horizontal canal. We retest the patient after 20 minutes, and on leaning we can see a slight upbeating left torsional nystagmus. Bowing elicits no nystagmus. Then we perform the upright head roll test for the previous finding of the horizontal BPPV, but it was negative. And we test the patient again with the roll test, and in the head yaw test in the left position, we see that the, the upbeat left torsional nystagmus appears and has a persistent nature. The nystagmus increase its velocity and presents with this persistent non-paroxysmal velocity pattern. When we sit the patient up, the nystagmus persists transiently. Then I tested the this whole pack maneuver that it was negative, and on sitting up from left this whole pack maneuver, after some latency, we can see how the patient perceives a retropulsion and an upbeating left torsional nystagmus starts beating. Then we test the nose down position and we can see a lighter persistent downbeating right torsional nystagmus, suggestive of an inhibitory deflection of the left posterior cupula. So we think that the cause of this clinical picture was the movement from the anterior arm of the left horizontal canal towards the posterior canal short arm and the sitting up BPPV syndrome. So we saw that sitting up vertigo and sitting up nystagmus could be a epiphenomenon of the posterior canal heavy cupula and the posterior canal short arm canalolithiasis. But what could be the mechanism involved in the nystagmus itself? So one possible mechanism could be that the detached debris that is located in the utricular side of the posterior canal cupula in the short arm canalolithiasis, but also could be some uh, amount of detached debris in the in the heavy cupula associated to cupulolithiasis, move to the short arm opening or towards the vestibule when the patient extend their neck on the on the disc hold back maneuver or in straight head hanging maneuver. And then when the patient sits up, the debris will fall again towards the cupula by action of gravity, eliciting an ampulofugal stimulatory deflection and then the upbeating ipsitorsional nystagmus. Bucchi and Schwarzman have used this hypothesis as putative mechanism in the BPPV type 2, but they didn't found or they didn't show any oculomotor evidence that supported. You can see here an animation that describes the mechanism. Another possible mechanism could be a disruption to posterior canal cupula adaptation. As we mentioned earlier, in the sitting position, the incidence of the gravity vector on posterior cupula is not maximal, but it's not neutral. So a set point adaptation process should probably take place. The stimulation on performing positional maneuvers could transiently disrupt such adaptation, thus making visible the stimulation of the posterior cupula on sitting position in the form of the sitting up nystagmus till the adaptation takes place again. Mechanism could be related to an overflow of the rotation feedback mechanism on the velocity storage. In normal conditions, the sitting up movement from this hold pipe maneuver elicits a posterior cupula ampulopetal deflection mediated by the endolymph inertia. When maneuver stops, a transient cupular ampulofugal deflection is produced by the moving endolymph in a phenomenon that is known as canal rotation after effects. We are not normally aware of such phenomenon since, in normal conditions, a corrective rotation signal of angular velocity opposite to the one produced by the canal rotation after effect is produced by the rotation feedback mechanism on the velocity storage, and the rotation canal after effect is cancelled. We hypothesize that, on sitting up from this whole pike maneuver in the context of a heavy posterior canal cupula, the gravity influence on cupula should elicit an abnormal and variable stimulus. Initially, at this whole pike position, a neutral or slightly inhibitory posterior canal cupula deflection is expected. The ampulopetal deflection expected during the head rotation could be altered by the simultaneous ampulofugal force mediated by gravity or by a different cupular dynamic. During the head rotation, gravity will exert an increasing force over cupula that will tend to deflect it ampulofugally till it reaches its maximum when the head is flexed by 30 degrees. From there, a decreasing but still ampulofugal gravity-mediated force is expected till the head reaches the sitting position. When the rotation stops, the gravity-induced ampulofugal excitatory deflection will add to the ampulofugal deflection mediated by the moving endolymph to then deliver an enhanced and abnormally persistent canal rotation after effect signal to the velocity storage. That anomalous rotation after effect will cause a large difference between the direction of gravity estimated by the integration of semicircular canal signals and the outlet signals, surpassing the correction capabilities of the rotation feedback mechanism, thus producing a nystagmus in the direction of the inhibited cupula during positioning. Here, an upbeating torsional nystagmus and a forwardly tilted estimated gravitational direction with a consequent retropulsion. A similar mechanism has been proposed for central paroxysmal positional nystagmus, where the abnormally enhanced rotation after effect is elicited by the disinhibition of irregular vestibular afferents, usually in the context of lesions involving the nodulus and the uvula. Just one patient in our series showed the typical persistent upbeating torsional nystagmus on this Holbach maneuver. 9 out of 11 heavy cupular pattern patients and 2 out of 5 short arm canalolithiasis pattern patients exhibited subtle, sustained, and asymptomatic downbeating torsional nystagmus on this Holbach maneuver, eh, contralateral and ipsilateral, and in straight head-hanging maneuver. This finding could be the result of an ampulopetal cupular deflection mediated by gravity if this heavy cupula was utricularly angulated, and another mechanism behind this downbeating nystagmus could be the expression of a posterior canal cupula adaptation to a persistent ampulofugal deflection on sitting position that is relieved or diminished on neck extension during positional maneuvers. Clinicians should be alert of these variations since the presence of downbeat nystagmus on this whole part or straight head-hanging maneuver could be erroneously interpreted as other vertical canal BPPB variants such as apogeutropic posterior canal BPPB or anterior canal BPPB or a central positional nystagmus if graviseptic cupular signs were not looked for or were overlooked. So, as conclusions, we can say that sitting up nystagmus could arise from heterogeneous mechanisms. The benefit of Randarov exercises over canalate reposition maneuvers in our series is probably due to the fact that otoconia is not inside the semicircular canals, and this approach has better potential for detaching otoconia from cupula and for disaggregating free-floating otoconia on the vestibulum and on the posterior semicircular canal short arm. Therapeutic approaches will vary depending of the mechanism involved. We also try prolonged false position and domiciliary demi-Simon maneuver as used for apogeotropic posterior canal PPPV variant with success, but we have not yet compared different approaches in a randomized trial in order to compare effectiveness. And we have to underline that the syndrome could be very subtle and it could be missed if not explicitly looked for. This patient had had positional vertigo 72 hours before. He got better but remained dizzy and out of balance. And on examination, we can see this very subtle upbeating right torsional nystagmus. We should be very alert in order to see that finding. When we test the whole pike maneuver, we can see how a sustained upbeating right torsional nystagmus appears. And in nose down position, we can see the downbeating contratorsional nystagmus. So this variant could also be very subtle, so we have to be on the alert when examining the patient. We should look for it because if we don't, we will probably not find it. So whole pipe position and nose down position are very important in order to not not overlook this diagnosis, and this is a differential in which we have to think in a patient presenting with downbeating nystagmus, a positional downbeating nystagmus, and we think this mechanism could be related to post-canalite repositioning maneuver or residual dizziness in some patients, and we are prospectively evaluating more patients with these findings in order to better understand it, but they are very unusual. So thank you very much for your attention, and special thanks for the team of the neurotology unit at Favaloro Foundation with Dr. Garcia and Dr. Barreiro.